treatment. Wild Bulls records his own conversion from medical to surgical treatment in convincing fashion. He cites 78 cases who 3 years after nephrectomy were divided as follows: 59% alive and cured, 21% alive but tuberculous, 20% dead. To compare with these, he collected 316 cases under observation at various sanatoria in Switzerland. 70% of these had died within 2 years, and of the 98 survivors, 68 still suffered from urinary tuberculosis, while only 30 had been relieved of their symptoms. In 16 of these, the clinical cure had persisted for over 5 years, but after years of apparent cure, sudden breakdown and death were known to have occurred. The classical contribution on nephrectomy for tuberculosis is that of Israel. He collected 1,023 nephrectomies with a mortality of 13% in the first 6 months, and as many more later, half of the later mortality occurring in the period between the first 6 months and the end of the second year, and due chiefly to pulmonary tuberculosis, renal disease, and acute miliary tuberculosis. The Mayos, up to 1912, had performed 203 nephrectomies for tuberculosis with an immediate hospital mortality of 2.9%. Crabtree reports 103 cases from Cabot's clinic with an immediate mortality of 3.8%. I have performed 65 nephrectomies for tuberculosis, with 2 deaths before the patients left the hospital and 3 more during the first 6 months thereafter. After treatment. The after treatment must cover the patient's general condition, the persisting tuberculous cystitis, and the loin sinus. Nephrectomy is only the foundation stone of a cure. With it, the cure begins, but this will not proceed unless the nephrectomy is followed by an intelligent course of anti-tuberculosis hygiene, a compound of fresh air and overfeeding, and the intelligent use of tuberculin. This course may be profitably continued for at least a year, even in the most favorable cases. The rules for the treatment of tuberculous cystitis, if this continues to annoy the patient, are laid down in the next chapter. A loin sinus persists for at least 2 or 3 months after at least 50% of nephrectomies for tuberculosis. Its healing may be hastened by cutting down granulations and use of the beer cup. Exceptionally, the whole wound will break down and become tuberculous. In this event, no complete healing may be expected within 1 or 2 years. I have known such wounds to remain open for 3 years and to heal at the end of that time. Heroic measures do not hasten healing. Contraindications to nephrectomy. The contraindications may be found in the opposite kidney or in other organs. Of the general contraindications to nephrectomy, we need only mention active tuberculosis elsewhere in the body and myocarditis. I have never been deterred from performing nephrectomy by the fact that the patient's lungs showed signs of apparently healed tuberculosis. Indeed, I have once performed nephrectomy successfully under local anesthesia in the face of a rather active pulmonary tuberculosis. In one other case, however, my medical counsel declared the patient's lungs quiescent, I removed a tuberculous kidney, and the patient died a few weeks later of his pulmonary disease. In another case, I braved a mild pulmonary lesion, and the patient died 5 months later. The condition of the patient's circulation is of the utmost importance. A rapid pulse before operation suggests the possibility of myocarditis and the propriety of a preliminary week in bed on digitalis. I lost one patient on the 3rd day after operation through myocarditis and have nearly lost several others. Israel regards this as a frequent cause of post-operative death. The condition of the opposite kidney is also important. It may be congenitally deficient, page 532, otherwise diseased, the seat of tuberculous nephritis, or the seat of active tuberculosis. I've never known tuberculous nephritis to be a valid contraindication to operation. Tuberculosis of the opposite kidney was for a long time considered a contraindication to nephrectomy. This it certainly is not. If there is no great difference between the functional capacity of the two kidneys, there is quite obviously no reason to remove either one of them. But if one is gravely infected, the other only slightly involved, the gravely infected kidney should be removed. I have had the happiest results from following this course of action, although I must confess that one of my immediate deaths was the result of an attempt to help the patient by removing a kidney, which after all was not much more diseased than its fellow. But fully half of the cases of bilateral tuberculosis with grave unilateral involvement will not only survive, but will be greatly improved by operation. They may grow fatter than they had been before operation and may consider themselves practically cured. Their death, when it does come, is likely to come quickly and as a result of total destruction of the renal parenchyma. Thus, one patient of mine wrote me a letter last June, thanking me for the 2 years of good health he had enjoyed after taking an equal length of time to recover from his operation. But this man died of renal insufficiency 4 months later. Another case, one of renal tuberculosis for 11 years before operation, survived the operation 4 years. At the end of the 3rd year, she weighed more than she ever had in her life and was all but well. A year later, she died very peacefully of renal insufficiency and pulmonary tuberculosis. To sum up, the contraindications to nephrectomy for tuberculosis are 1. Any general condition contraindicating a major operation. 2. Active tuberculosis elsewhere in the body in such variety as to contraindicate a major operation. This includes almost all cases of pulmonary tuberculosis. 3. Tuberculosis of the opposite kidney, so far advanced as to impair its phenylsulfonaphthalene elimination below 30% per hour after intramuscular injection. 4. Any other kidney lesion, congenital or acquired, markedly reducing the function of the kidney. 5. Marked tuberculous nephritis of the opposite kidney or tuberculous myocarditis sufficient to make the pulse persistently rapid are warning signs, but not contraindications to operation.